The vertical chop is a very useful technique for hard cataracts. However, there are several nuances to this technique that makes it not very straightforward as horizontal chopping. In this video, I'll show my technique for vertical chopping. For vertical chopping, you need a sharp chopper with a sharp tip, and especially a long one. This is a Seibel safety chopper, which is a nice one. I like to make a little bit of a groove, impale vertical as much as I can in that groove, so have a deep purchase on the lens, and then you bring the chopper just in front and you press down, and then you get a first separation. I like to sometimes rotate 180, just make sure that I can accentuate that crack and make sure I got a full thickness crack as here. The next step is just to keep repeating it. Again, note that the force is actually 80% down, 20% up, and then separation. So it's not only coming down, there's a bit of coming up after you have a good purchase on the nucleus with high vacuum. This is a vacuum of 500 millimeter mercury, constellation, and aspiration of about 40 cc per minute. And here, just keep going. It's best for vertical chop to leave the quadrants or the pieces of the nucleus in place to give a lateral stability to the other pieces until you start evacuating out. And now once you have a split, it becomes easy. The first quadrant or first part of the nucleus to take out is usually the most difficult because still some lateral attachments, but after that it becomes easy. And there's a nuclear grade 3 at least cataract, and the vertical chopping works so well really for these hard lenses. Here is near the end of the case. What you want to see here is you are phacoing in the center. This is the safest part of the NT chamber, away from the capsule and away from the cornea. You want to see things moving, so if the quadrants are not moving, then you can help that with the chopper. Also, whenever you have full occlusion and nothing is happening, then you put your foot down and put more ultrasound, and that's what I usually tell the residents. Full occlusion, nothing happens, then you need ultrasound. And that's here the end of the nucleus removal. Thank you so much for watching.